Their immune function is so jacked from their hyperinflammatory response that it would benefit from steroids. By the time they have come to the ICU, I don't think I'm really treating the infection as much as I'm treating their response to the infection.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow in Washington, D.C.
Today, we're excited to have Dr. Nadir Yehya back with us on the podcast. We're concluding our 4-part series on advanced topics in pediatric ARDS.
Yes. Today, we're going to be talking about the adjunctive strategies for ARDS treatment. Nadir talks about nitric and he talks about proning, and he actively in real time changed the way I feel about paralysis and steroids.
That's right. That's the impactful conversation we have here at PedsCrit.
Yeah, listen for more.
That's right. Let's get right to the content. So now that we've suggested several times about all these other adjunctive strategies, I'd like to just explore, what type of patients would you certainly always provide these strategies? Which ones would you may consider plus or minus? And which ones would you certainly not? You've already suggested some of that with the various modes of mechanical ventilation with regards to paralysis.
Absolutely.
So the ones I wanted to explore are corticosteroids, prone positioning, nitric oxide, and maybe even surfactant.
Oh, okay. Corticosteroids have been looked at for a long time. Neuromuscular blockade have been looked at for a little bit less. Nitric's been looked at for a long time, and surfactant comes in and out of favor periodically. And the cheapest of them is proning, which is probably also the most efficacious of them. They all have strong physiologic plausibility. Their expense is different. Their invasiveness is different. And I think that ends up determining how different institutions have interpreted their own willingness to use or not use. But all of them have a strong biological plausibility for working in ARDS. I can go in the order that you listed, or I can go in how I think about escalating.
Ooh,
I think that'd be more helpful.
Order, yeah.
So I tend to go in the order of least to most perceived invasiveness and risk-benefit. So for me, that very often actually involves neuromuscular blockade first. Neuromuscular blockade first has the advantage of me getting accurate ventilator pressure, so their own negative pressure of 10 or 20, whatever that is, goes away. I know exactly how stiff their lung is, and I can titrate my pressures accordingly. I also get rid of the dysynchrony element, which is contributing to both hypercarbia and hypoxemia. If their hypercarbia is being caused by ventilator dysynchrony because they're dyspneic and I can't capture them, or if their hypoxemia is being caused by a heterogeneous ventilation perfusion because parts of their lung that they're perfusing are not being particularly well opened, then some of that can be relaxed by neuromuscular blockade. Okay, some of that can be smoothed out, and at least neuromuscular blockade has the advantage of giving me accurate pressure measurements for the disease process. So I feel that very often tends to be one of the first things I do. The risk of that is, of course, the prolonged neuromuscular blockade, okay, and then deconditioning that's associated with that. And the cisatracurium trials for 48, 72 hours suggest that you can get away with some short-term neuromuscular blockade to capture ARDS without a significant increase of that. So you just need to know that there's the risk of the therapy that you're offering. But I have often found that there's many patients who are difficult to control unparalyzed who are easier to control paralyzed. And easier to control also translates to better gases. And so my hope is that eventual ease of control also translates to shorter time on the ventilator ultimately. So I hope that I'm doing right by them in the long run. My next step actually tends to be prone positioning. Okay, and prone positioning has strong plausible adult data, and prone should work a couple different ways. So prone positioning redistributes ventilation perfusion in such a way that is more favorable, but probably the more important mechanism by which prone positioning works is that there's a lot more lung in your back than there is in your front. Because your heart's in the center of your chest and is fairly compressible, but is also pretty strong, you tend not to compress the anterior lung fields quite as much. And so prone positioning opens up a lot of your back lung in such a way that you actually homogenize your redistribution of air in a more favorable way. We alluded to this earlier. When you're supine ventilating and you have ARDS, if you guys take a breath in and out right now, right? Your lungs expand and contract in a relatively homogeneous manner that's very fluid-like behavior. Everything kind of behaves all the same, right? When you have ARDS, okay, and you're ventilated on your back, that is not true. What you have is a combination of solid and liquid state behavior where the rock-like atelectasis and consolidation and edema, those unopenable lungs take on rock-like behavior. And then the rest of your lung, which is tethered to it, takes on a more liquid behavior. But a consequence of that is that you're actually causing a fair amount of damage, or could be causing a fair amount of damage, because now it's not like just a balloon that's being overinflated. It's a balloon that's being taped to a rock that is getting overinflated. And so there's an additional stress that's exacerbated. It's a force multiplier by the fact that it's still stuck to this rock-like behavior. Okay? So the goal of ventilation isn't just to provide safe oxygenation and ventilation, but actually you're trying to move back toward liquid state behavior. And so you're trying to rehomogenize the lung rather than this heterogeneous air rate on top, consolidated in the back. So prone positioning, by re-recruiting all that lung, should allow your driving pressure to come down, your pips and plateaus to come down. And what it's doing is spreading all that air over more lung. So you're re-engaging all that lung and reopening it all and moving closer toward liquid state behavior. So those combination of things make prone positioning very effective. Also, a whole bunch of secretions, if they're there, could potentially get mobilized by prone positioning, because now you're getting some sort of postural drainage by like being on your belly. And so some of that may actually be also recruitable lung if those things are out of the mix. So neuromuscular blockade, then prone positioning. When that's failing, and I'm starting to think of other modes of ventilation, here is where things like nitric oxide versus other modes of ventilation start coming into play for us. They're already paralyzed and prone. Okay, then would I do nitric then oscillator or oscillator then nitric? Maybe I didn't want to prone them. Maybe I actually wanted to actually leave them unparalyzed and actually try APRV first is a consideration. And so that could have come before the paralytic step. In patients, I'm willing to prone. I'm willing to keep paralyzed because I don't think they'll be particularly good APRV candidates, but I don't want to move to the oscillator yet. Okay, then I would go down a paralysis and a proning and then think of alternative modes of ventilation because I can do all that on the same circuit. Then nitric comes in somewhere in there at around the same time that I start thinking about other modes. The advantage of nitric oxide is that the improved ventilation perfusion matching and hypoxemia rescue, may keep you from needing to go to another mode of ventilation. All right. And people say that nitric improves oxygenation without necessarily improving outcome. But if the mechanism of nitric oxide is to improve oxygenation, and that keeps you off of ECMO, or if that keeps you off the oscillator, and if people can wean conventional ventilation faster than they can wean the oscillator or they wean ECMO, then you've actually saved ventilator days. And so I think that large enough, well-powered, well-designed trials to actually prove a clinical benefit of nitric oxide are still in the works, but the physiologic premise of it is still there. So in patients who are premature, who may have underdeveloped pulmonary vasculature, or patients who on echocardiography may have some evidence of right ventricular strain, or induced pulmonary hypertension, not pH at baseline. I think if a patient is on sildenafil at baseline, I think many people will reach for nitric oxide sooner rather than later when they get sick. But I think even if you have evidence of RV strain or some degree of RV dysfunction on echocardiography, there's plenty of patients who develop minor cor pulmonale, without being full-blown pH with ARDS. You can tighten up those vasculature. You can certainly induce afterload resistance and stiff lungs and things like that. And if you're starting to affect your heart, then if some benefit could be obtained by relaxing some of that, or if you're premature and you're a preemie who doesn't carry a pH diagnosis, but you have half the blood vessels as another 6-month-old, then you may not have pH when your cardiac output is 2 liters per kilo per minute, but when you're in shock and your cardiac output is trying to go to 3 liters per kilo per minute and it cannot force itself through your underdeveloped blood vessels, well, pressure equals flow times resistance, right? So if I try to double my flow, but my resistance is the same, I've increased my pressure. There's plenty of preemies that would benefit from nitric oxide when they're sick who would not meet criteria for pH when they got their cath or their echo when they were well. Those are populations that I may reach for nitric oxide sooner rather than later. Preemies, underdeveloped lung disease, or some evidence of RV dysfunction on echocardiography. As a blanket rule, I think it may just be too expensive of a therapy outside of trials to try in everybody with ARDS, even refractory ARDS. So what have we gone through? We've gone through everything except steroids and surfactant, I think.
Yeah.
That's right.
Yeah. Steroids. Steroids have a good amount of data suggesting that they in adults, that they can improve lung injury. So from the initial Maduri trial to the follow-up Lazarus trial to more modern dexamethasone, dexa-ARDS trials. I believe most, if not all of them, demonstrated some improvement in compliance and gas exchange. What they don't consistently improve is that you get people off the ventilator faster, or they're worth the side effects of neuromuscular weakness and or rebound hyperinflammation. Okay. The other thing that people don't like is that the initial Meduri protocol, so for 20 years, from like 1998 onward, what we had was like 4 weeks of solumedrol, which is like a long time to be on like solumedrol. It's like an asthma burst is like 5 days, and people are like, what, you want me to do this for 28 days? And so that, I think, also made people a little hesitant to think that the risk-benefit ratio played out in favor of solumedrol, particularly for early ARDS. Maybe for refractory ARDS, it was something they would reach for on days, 2 through 7, but maybe not on day 1 or 2. The DEXA ARDS trial was a trial of patients who got assigned like dexamethasone, for 10 days, which people like more than 28 days. And they did that relatively early, like by day 2 of ARDS. And so even there, like steroids do play a role. So for me, by about the time I've proned you, I've started steroids, because this falls into my algorithm of less invasive with perceived risk-benefit ratio. Okay, and now these days, preferentially, I do dexamethasone. So now for this patient, before I'd flipped him to APRV, unless I just thought that like I could get by with APRV and tolerate his degree of hypoxemia, my own practice would probably have been paralytic, prone steroids, then oscillator, then ECMO. Plus minus nitric somewhere in there.
And you think about your steroids as part of the escalation algorithm as opposed to being like, we're on day 3 to 5, now it's time to start type of thing.
Correct. Like even in CHOP, we're probably about 50-50 in terms of how we think about this. I think the people who do respiratory research reach for steroids earlier, I've noticed, than the people who don't do respiratory research. The people who don't do respiratory research still think of steroids, I think, as like for refractory ARDS rather than upfront ARDS.
What if you're really impressed that it's a bacterial pneumonia and it's in there?
Then I do it sooner.
Okay.
The steroids at the doses that we use, there's no good evidence that they're immunosuppressive in any meaningful way. If you told me that anything shy of like this bone marrow transplant patient, this neutropenic patient is growing aspergillus or rhizopus, anything shy of an actual mold that I'm like, you straight up need a neutrophil, then no. The same people who did trials on like bacterial meningitis, that's a brain infection the last time I checked, put dexamethasone on that. And like that is not immunosuppressive, but this one is not. At the doses and the steroids we use, and the 2 per kilo of methylpred a day or like 0.3 per kilo of dexamethasone that we extrapolate the adult dexamethasone dose to, it's not meaningfully immunosuppressive. For the patients we take care of in the ICU. So this risk benefit is, I think, a very ICU specific thing. And this is an important caveat in my opinion. Are steroids immunosuppressive? Yes. Will they kill off some white cells? Yes. Will they increase your propensity for future infection? Yes. Is the reason most patients in the ICU because of their infection? No. Most patients have made it to my attention because of a dysregulated immune response to something their body should have been able to handle, but it couldn't. It's the immune response I'm actually treating and not the underlying infection. The underlying infection will either run its self-limited course with adequate innate immune function with or without steroids, or their immune function is so jacked from their hyperinflammatory response that it would benefit from steroids. By the time they have come to the ICU, I don't think I'm really treating the infection as much as I'm treating their response to the infection. And that has demonstrated to be dysregulated. So I actually think the mental model of steroids being immunosuppressive cannot necessarily extrapolate to critically ill patients. There's benefit for prednisone and methylprednisone in community-acquired pneumonia, but really only in severe community-acquired pneumonia. Mm-hmm. Plenty of evidence of solumedrol in benefiting lung injury in ARDS, maybe not improving outcomes because of rebound inflammation and neuromuscular weakness, and secondary infections. But that may have more to do with the duration and timing than it does with the actual concept of steroids. The DEXA ARDS trial, also confirmed that there's a benefit to reducing the inflammation in ARDS. There's plenty of hydrocortisone trials in sepsis. That's sepsis. That's like, by definition, suspicion of infection. And we use the equivalent of 1 per kilo per day of methylpred in those hydrocortisone trials. And the logic there is to try to improve the shock. That's a situation in which, like in very severe pressor refractory shock, we're willing to give this nominal immunosuppressant because we're not treating the infection. We're treating the immune response to the infection, which may benefit from steroid. By the time you come to the ICU, I think the concern about immunosuppression is attenuated somewhat by what you actually are treating.
Nice.
Yeah, makes perfect sense. I got a few rapid fire follow-up questions for you, if you like. All right, so you're dosing of steroids. Are you getting me like 0.2, 0.3 of dexamethasone per kilo per day?
The adults were like 20 for 5 days and 10 for 5 days, and we like just kind of half-assed that into 0.3 and 0.15.
And you're thinking about 5 days or based on clinical trajectory?
10 days total, 5 days at 0.3 per kilo, 5 days at 0.15 per kilo is our current pharmacy-approved protocol.
Nice. And a max of 20 and 10.
And a max of 20 and 10, correct, yeah. There's occasionally like random brain tumors that get ARDS or somebody who's on dexamethasone for some other reason where we just let them run their protocol because those doses tend to be comparable or higher, if anything, than what we would end up using. But no, if we're doing it for ARDS, it would be at those numbers.
And how does providing corticosteroids affect or doesn't affect your role of neuromuscular blockade?
It doesn't for me. It does for some of my colleagues. And I think around the country, I think people like notice that as well. The prevalent use of cisatracurium in the trials versus the prevalent use of vecuronium and other neuromuscular blockades and thinking that they're all the same thing, I think that probably is fraught with some degree of inaccuracy. Cisatracurium is thought to be less, even in combination with steroids, has not really been demonstrated to be like quite as muscle wasting, whereas vecuronium may be. I think that different neuromuscular blockades may in fact have different properties, and they may interact differently with steroids to cause a different risk-benefit profile. I get past that by trying to limit my use of neuromuscular blockade to like only the acute phase. And if I am doing it longer, given that the steroid course is like 10 days, then like I try to be cognizant of which neuromuscular blockade I'm on and either switch to cisatracurium if I feel like this patient still needs to be paralyzed, or try to change some things around that I'm at least cognizant of it. All of that being said, if everything kind of plays out to a risk-benefit ratio, certainly kids get deconditioned, and this is something that I may be creating more problems for myself in the future that we just haven't investigated fully yet, but it hasn't impacted how I prescribe those two medications yet. If I start seeing data suggesting that I've ended up creating a new generation of people who are like BiPAP dependent or trached because of some of these maneuvers, and as your survival improves, then this will happen. There will be some version of this that happens, of deconditioning, and like the quality of survivorship is going to decrease, but your overall number of survivors will increase. And there, I think it's incumbent on us as a field to like test out, like, rather than like immediately say that like we shouldn't be using neuromuscular blockade and steroids, because the counterfactual to that is like, well, then yeah, but then you would have had 5% extra mortality. And so I think actually like teasing that out in the future of actually seeing like what that actual balance is an important area for study. We have started to get to the place where good supportive care and consistency of protocols is getting us in the 15 to 20% mortality range for ARDS, such that instead of the 40% where it was in the 90s. And so I think for that in pediatrics, I think that now requires us to ask the question of like, can we improve the quality of survival at this point? But I don't currently use that background info as a way to drive my immediate medication choices, simply because like I don't know if like pulling back on things will actually just re-increase the mortality rate, particularly in these sick kids, okay? Because the confounder for like retrospective studies looking at steroids and neuromuscular blockade is again severity of illness, okay? So somebody who's IL-6 and IL-8 and TNF levels and their sepsis, ARDS are so bad that they needed neuromuscular blockade and steroids, their inflammation is probably so bad that it made them so catabolic that they tore up their muscles. So like, was it my therapy or was it the severity of the ARDS that caused this? Okay, I'm not confident that a retrospective association between steroid and neuromuscular blockade or two sick kid therapies being associated with more weakness is causal. Although it probably contributed. I'm not naive enough to think that like my therapies don't have any side effect. I just don't know if it's proven strongly enough for me to change practice based on it yet.
Yeah, I understand. A couple questions about prone positioning. How long do you make a patient prone to see if they're going to actually physiologically respond? And before you intubate, would you ever put a patient on non-invasive prone to prevent intubation?
Yes, and 16 hours. At least.
16 hours?
16 hours at least. Yeah, so we're part of the Prospect trial, the prone oscillate 2x2 factorial design, which is really like a 4-arm trial that's having adaptive randomization. But that protocolizes, I think, about 16 hours of proning at least. And I agree with that. Like, I think most of the adult studies say 16 or more hours of proning a day because most of the benefits in the prone position. So 16 to 20 hours is what most people do. And for ARDS, that's what I would do. Would I ever prone somebody? We have. Actually, like, I think COVID made us more comfortable with all of this. We're willing to keep somebody on CPAP or BiPAP and periodically, like, awake prone them. I know there's been a lot of talk about how different is COVID ARDS from regular ARDS from other and ARDS has so much heterogeneity that, like, this one other inciting risk factor adding additional heterogeneity, like, can sometimes get lost in the wash. But it did prompt some conversations about hypoxemia out of proportion to dyspnea. And that may respond particularly well to ventilation perfusion redistribution. And so in that sense, okay, I think a lot of people start doing things that they weren't necessarily comfortable with earlier, particularly like if it ended up changing your nursing ratio in such a way that your understaffed, short-staffed, ICU couldn't handle if you intubated this patient, whereas like it could probably tolerate you messing around with prone BiPAP for a while. And then people are like, oh, I could do high flow prone, I can do BiPAP prone, things like that. And this patient's texting on their belly now and their sats are better. And so like, I think that taught us that we could do it. I think that physiology within the heterogeneity of COVID ARDS was the physiology of disproportionate hypoxemia that may particularly benefit from VQ redistribution. So yes, I would do it. I would also, however, the first thing you asked me about the 6-year-old back in the day is when would you intubate this patient? And this is another time where I would like think about expected natural history and speed of trajectory. This is not a maneuver I would mess around with if I fundamentally thought that like this is going to get substantially worse before it gets better. But in an isolated case of like a teenager or like an older kid who I could potentially reason with, who would follow direction, who would stay prone, who I actually think I could potentially capture, yeah, maybe.
Yeah, good. Nitric. How do you determine if they're a nitric responder? How long are you going to leave them on that therapy if they don't necessarily respond? And then how do you just pull it off altogether, or do you wean it off slowly?
Yeah, that's a great question. Nitric response, if it's being started for ARDS and not a cardiac indication, like I did mention the RV dysfunction and things like that, in which I like soften things a little bit. But if I'm doing it for ARDS, our protocol strongly recommends pre-post blood gases and or pre-post documentation of improvements in saturation and FiO2. So our experiment is 30 to 60 minutes. Our documentation should be at least pre-post by an hour, and try not to do too many other things when you're doing it so that you can get accurate numbers. Don't like double your PEEP while you're doing this, man. Just try to keep it clean. But our protocol does actually like explicitly say try and get pre-post. And if not, if they're a non-responder, which is defined as less than a 20% improvement.
In PaO2 or what?
PF actually, but that translates pretty much to PaO2 if you're like keeping your FiO2 constant. And SF, technically, if you don't have blood gas, but a lot of these patients have blood gases by then because they're the sicker ARDS kids. In that 30 to 60 minute, 20% improvement, what's supposed to happen is abrupt discontinuation if they're a non-responder. If they were determined to be a nitric responder and kept on nitric, when we are weaning nitric in the weaning phase of ARDS, after they're like somewhere around the time that your like PEEP is in the 10 to 14 range, your paralytic's coming off, the nitric should be coming off. And we have a protocol to reduce nitric systematically so that it's off over 24 hours. And you can make concurrent ventilator and paralytic changes if you want to with that. But our nitric weaning protocol is something like 20 to 10 to 5 to 2 to 1 every like 4 to 6 hours or something like that.
Sure.
Yeah. And we try to protocolize this for 2 reasons. One reason is because it's written down somewhere. So like I have an idea about things, but like I round on patients and I take care of 15 patients where like the boots on the ground are my nurses, respiratory therapists, and residents and fellows of varying degrees of expertise, comfort, and training. Right? Mm-hmm. And so everybody needs to have a similar mental model or framework for doing this. It doesn't matter if I know what's going on. I'm not going around like dicking around with like 15 nitric knobs. Mm-hmm. Not all 15 of my kids on service are on nitric. That would be ridiculous. But if they were, I wouldn't be the guy going around changing them. So having a protocol allows some sort of a shared mental model that can be disseminated or at least pointed to by like all levels of providers, okay, who are caring for a patient. 2, having a protocol also empowers nursing and respiratory to protocolize things within their scope of practice that your resident who may not have quite as much experience or your fellow who may not have quite as much comfort with like changing things overnight, it empowers everybody to be like, this is the right next thing to do. So it gets away from the tendency of overnight, oftentimes covering providers. And I'm not going to break balls here. We've all heard like, I'm just covering. But it gets away from that and gets it more toward like everybody agrees that this can be weaned. Okay, sort of thing. It empowers respiratory therapy to say like, we should wean this now. It empowers nursing to say, yeah, we're ready to wean. And then everybody feels good about it, as opposed to saying, let's just ride it out till the morning, sort of thing. And so it actually speeds things up if you have like a protocol in place with guardrails so that everybody is using all of their training to the best of their ability for the kid.
Oh, yeah. Very good for hospital systems, especially because we're only there for 12 hours at a time.
Exactly.
My last adjunctive question. As an early first-year fellow, I was taking care of a child with ARDS who had a history of prematurity. And the parents asked me, what about surfactant? When we were in the NICU, she got surfactant.
Oh, yeah. That's a great question. I had forgotten about surfactant. So surfactant got hot for a bit by the same logic in both adults and pediatrics, like in the 90s and the aughts. And the idea was that surfactant dysfunction is a major contributor to ARDS because all that pulmonary edema and all the inflammation, all those things are like surfactant activation. In neonates, neonatology, RDS is a surfactant deficiency. So surfactant replacement makes complete sense there. Some of their other diagnoses, like meconium aspiration, are also very direct surfactant inactivants. And so, again, surfactant replacement makes a lot of sense there. Extrapolating that to inflammatory ARDS with pulmonary edema runs the risk of delivering surfactant therapy bronchoscopically or blindly to a bunch of flooded alveoli where it will just get diluted. So, the premise of surfactant in ARDS is not quite as strong as it is in RDS and neonatal disease processes in general, which are more consistently surfactant deficiency processes. In ARDS, it's possible that if you're bronchoscopically delivering it, you may still be getting it diluted, so you're not delivering as much surfactant as you thought you were because you're delivering it by definition to flooded alveoli. And if you're delivering it blindly, like just through like a catheter and you're turning the patient to the left side, to the right side, you don't know necessarily where it's going. So in 2005, after the publication of the initial calfactant trial, there was a lot of enthusiasm for surfactant. I will remind people that that was a negative trial. Like the primary outcome of ventilator-free days was not different between the two. But, all that being aside, there's a clear mortality benefit. However, that mortality benefit became less clear when you adjusted for the fact that there was an imbalance in the randomization of the number of bone marrow transplant patients or immunocompromised patients between the two arms, so that there were more immunocompromised patients in the control arm. So the mortality benefit seen with surfactant may have been due to imbalanced treatment allocation or like case mix of the two arms rather than to surfactant itself. That being said, there was a lot of enthusiasm about it because it looked like surfactant in that trial actually did improve oxygenation. So people had a plausible mechanism between improved surfactant, improved oxygenation, improved mortality. So it made sense, right? The caveat to that is that the way that they delivered surfactant may have effectively been also a really good recruitment maneuver, where they bagged in the surfactant. So you may have actually just been really opening up some lungs and doing some of that de-escalating PEEP therapy that we talked about earlier, where you blast them at high pressure for a bit, let the surf get in there, and then, walk away. It wasn't necessarily the surfactant that did it. You just did a really good recruitment maneuver or some other mechanical thing that you could have accomplished the same thing with the oscillator or even just bagging a little bit higher pressures for a while versus surfactant itself. Follow-up surfactant trials have largely been negative, and the expense of the therapy has diminished enthusiasm for this as a thing. I think outside of trials, I would not use surfactant. I'd have equipoise if you came up with a better surfactant, if you came up with a better way to deliver surfactant, or if we wanted to participate in a pilot trial to demonstrate that a given mechanism of surfactant delivery improved a physiologic endpoint like oxygenation. I'd be willing to participate in all of those things. But as a therapy that I reach for, it is not there. And that's why. Some people try to make carve-outs for specific things like aspirations or drownings and other things that may invoke surfactant activation. But by and large, for most ARDS and PICU diagnoses, I always worry that you're just diluting a really expensive therapy in alveolar fluid. And so you're not getting as much bang for your buck, and it's a pretty expensive buck. I have twice in my life been called out by pharmacy for depleting the surfactant supply in the hospital during fellowship. And that meant that no neonates, some rando neonate that was born in our high-risk neonatology unit, had they been born, there was nobody due to deliver that night. But, babies come when they come, would not have had surfactant for a few hours. That's a problem, right? That's think about that. Because at the doses that they give them in for neonates are not the doses that are recommended, 80 per kilo or whatever it is for and I haven't given surf in 10 years now, but that's a known issue. And the volumes that you're giving for a teenager who has ARDS for surfactant is high. If you try to use the concentrated forms, then you worry that, like, is it getting there? Is enough of it getting to the right places? Whereas with the higher volumes, you're at least giving it, and you're like, yeah, it's probably getting somewhere. Okay, but then now you're worried about, like, using up all the surfactant in the hospital. So, like, for a therapy with unclear benefits, that consequential to a hospital and a hospital system, and you have other explanations for why those particular trials may have been positive, outside of better therapy, I'm willing to do it in a trial, but I'm not willing to do it, like, as routine care, even in sick kids. Like, I'll put somebody on ECMO before I give them surfactant. I may even call somebody as time of death before I give them surfactant, because that's how unconvinced I am. Although by then, yeah, maybe. But I'm not going to fault anybody for giving it at that point. But I'm not particularly convinced that it belongs in our armamentarium with our current evidence.
Were you called out pretty publicly? It
was a phone call at midnight. It was just a phone call at midnight. Okay. I'm willing to share. Yeah. It was like a call for the pharmacist explaining the consequences of, like, do you really want 150 mLs of surfactant? Because that's all the surfactant in the hospital. I'm all, that's what the math says.
Yeah, that's the dose. It's a large dose. It is visually impressive. Yes.
Yeah. So, I mean, if you're going to do it, I mean, it doesn't make sense to give half the dose if you're... You know what's more annoying? The oxygenation actually improved in that kid.
Uh-oh.
Yeah, I know. Now I don't know what to think. But no, despite that, I think that there's probably not enough evidence behind it to warrant it as routine therapy. And there's enough consequences to this being in your armamentarium that, like, unless your institution has bought into it, I wouldn't push it.
Nice.
I'd push nitric more because I think the risk-benefit ratio plays out better. It's an expensive therapy, but it's a relatively risk-free therapy. The kidney failure issue with it that's been consistently demonstrated is probably not as causally linked as people think, because it doesn't bear out in trials quite as much.
Oh, nice. So thank you so much for talking with us today. You've mentioned so many trials that you'd love to see happen and an appropriate design, which we very much appreciate. If you had to pick one thing that you think would move the field of pediatric ARDS management forward, what would be the one thing?
Vent settings. And I'm not disentangling, because in my head, PEEP and volume and driving pressure is hard for me to figure out how to operationally do one before the other. And I can probably figure it out. Like, you come up with, like, a PEEP FiO2 table or a PEEP strategy, and then you test volume, or you test delta P, or you come up with a fixed tidal volume or delta P strategy in pressure control, and then you come up with different PEEPs. And so, like, I can figure out how to do it. I just don't know which one's more important. But I think something about vent settings, that is fundamental to where our field is right now. Different PEEP trials could be like high versus low PEEP FiO2 tables, escalating versus de-escalating PEEP strategies like PEEP up, 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 or PEEP down, down, down. Start high, move low. PEEP with esophageal manometry or not. PEEP to find FiO2 of 50% or less versus PEEP to find delta P min. Okay, like, those are different ways to set PEEP. Could also be a plausible strategy. Like, do you prioritize oxygenation or do you prioritize mechanics? Because those will give you plausibly different PEEPs. Things like that, those would be very helpful, fundamental. Most kids with ARDS end up on conventional ventilation. So, like, I think that the move the needle trial is probably the how do you optimize conventional ventilation would be the first pass. When to intubate or not, or like when to escalate to an ancillary therapy or not, I think those are a little bit more niche, and probably major benefits of that are probably in a subset of ARDS. And so I worry that would be a harder trial to do, but I think you need to establish the basics for most comer ARDS first. And that to me is a supportive care of, like, is there a way to optimize conventional ventilation, or even individualize that if that's one of the strategies you want to test, as opposed to, like, blanket rules, like an individualized strategy for optimizing conventional versus, like, a blanket strategy for optimizing conventional. I think those, but whatever it is in that conventional ventilator space.
Nice.
Good. And I'll echo Alice. What a fantastic conversation. I've learned so much. This is your final open-ended question. Anything else you wanted to cover today? If not, feel free to reinforce a couple take-home points for our listeners. Most
ARDS can be managed with VV ECMO, even if you're on some amount of pressure. If you think that your pressure requirement is due to the ridiculous ventilator settings that you're using, or the inadequate oxygenation or hypercarbia causing acidosis, you will be able to wean those things on VV ECMO. VV ECMO is a much less morbid version of ECMO in most institutions. So if you have the expertise, if you're doing it for ARDS, even if you're on pressure and you get some pushback because of it being on pressure, most of those pressure requirements will be lessened with whatever ventilator settings you end up on VV ECMO. and with the improved gas exchange on VV ECMO. Okay, so in most ARDS, pure ARDS situations, okay, even with some pressure on board, if you think the lung is your major malfunction, okay, I would suggest VV ECMO first for most comers.
Thanks.
Well, look at you just teasing our ECMO series coming in later, maybe hopefully this winter on PedsCrit. So many things to get to.
Awesome.
Well, as we wrap things up, again, thanks so much. Really hope that many incoming ICU fellows will at least give this some time to listen to. So much perspective, so much practical bedside tips. And again, we thank you so much.
Oh, no problem. No, thanks for having me. It was a pleasure.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.